Thank you so much for inviting me. I'm so glad to be here. I have two fun facts, and I don't want that to count for my time. So I'm just First fun fact is I actually met Dr. Joe Stankaitis at an RWJ-funded asthma 3-year grant initiative, so we're always together on asthma. Together on asthma. That's the second fun fact is I do not play lacrosse, so I don't know if that helps us. So basically, I think that Joe really summarized the point of view of my health plan, which also is a not-for-profit. We are a provider-sponsored plan, and we are also a risk transfer model, which aligns incentives and encourages us, we're the clinical partnership department, to find ways to add value to the care that our providers and sponsors are rendering. All focused around the triple aim, with the goal of healthcare delivery that we all want, which is this coordinated care, patients at the center, we're huddling and everything is fine. But we know that for asthma, this is really what it looks like. And I think the challenge for all of us is the fact that the driver maps that we like so much in healthcare and other industries don't really work for asthma because there's so many factors that those who are living with this chronic condition have to address. And we're talking about the healthcare delivery system as being confusing and tough to manage and who's on which base, but asthma is very scary. I appreciate, John, what you said about the ED. Community-based people have a really tough time negotiating the delivery system. And I think that we have a tough time from the payer perspective, and maybe also, I suggest, from the clinical perspective, in dealing with all the kinds of drivers, because many of them are not within the 20% that we directly control, which, if you will, might be clinical care. So I just pose this as one framework to consider why it is important to think a little bit outside of the office, or even sometimes a school-based health center setting where we know we're encountering these children. I'm not saying that all we think about in those settings is clinical care, but I do suggest that that's where we have our most direct impact. And so we've become convinced that addressing the remaining 80% of the drivers that can impact not only quality of life but length of life is an important way for us to try to make a difference. So I thought I would add to this discussion a little bit of the way health plans look at data. I didn't put up the medication management data for New York State, for the city, and for our plan because it's extremely frightening. I just say that. But I will share that, this is HealthFirst data, 2014 through June 2015, it's claims data. And I'm showing you our ER utilization for children age 17 and younger living with asthma. And you can see that an ER utilization rate of 29 per 1,000 children with asthma, or 27 visits per child with asthma, really correlates with the significant burden of asthma department visits for children in New York City overall. And I would say the same thing about our asthma admissions. Here we're looking at a quality measure for our health plans in New York State. I want to really let you appreciate that in New York State, we are not only looking at return on investment in terms of bottom line for a condition like asthma, but there are multiple ways that we're measured and incented by New York State's health plans around asthma. And one is whether asthma admissions were potentially preventable. This is actually HealthFirst data, and what we're showing here, I'm just putting it up here because we know we have a challenge with helping our children and families and communities with asthma, is that this is a really interesting condition. We're very readmission focused and so on. This is an admission issue. And why that's should be a little bit frightening to all of us is that it almost correlates with sort of any child could be at risk for an admission, and we aren't always able to sort through the drivers fast enough. So we mentioned prevention. I'm going to really focus on the fact that we feel like prevention is really critical. Look at the data. 88% of our children who had a preventable admission for asthma had only one admission. I just paused there because I didn't get a sign yet. Okay. It's also a seasonal issue. And then also we have the challenge of the variability in how we manage children who, unfortunately, because of exacerbations, are being seen in the emergency department. This just shows the rate for, again, these are hospitals. 35 hospitals are recorded here in terms of their experience with ER visits versus an admission through the ER. Just showing you that there's variability even in how hospitals, let's say, are managing admission possibilities for children with asthma. So with all of this, you know, the data points to a few things. One, medication management, which is not really what we're discussing today, but medication management is a key area to focus on. There's variable management of acute exacerbations for which many children are at risk. And I think that the seasonality of asthma, which again is sort of an opportunity for us as we sort of think about potential interventions. So in terms of asthma initiatives, we have partnered with some of you, and some of these you'll hear about in detail later on today, to test some models for improving outcomes. The first one is the asthma IPM study that Dan Cass alluded to earlier, and you'll hear about it from Carrie Olson and Debbie Nagin later. But this is an intervention that will test the efficacy of integrated pest management. We focused in the Bronx, where a lot of our children with asthma live. Air New York City, again, you'll hear about this from Shoshana later. This has been a partnership that we've attempted to have for a long time, back when Air New York City was Air Harlem, if you will. And now we have found a way to collaborate with Air New York City. Again, all of these various reimbursement methodologies, I think, are how shall I say, innovative. But Shoshana will talk a little bit about what that intervention entails. And then we have been collaborating with the American Lung Association to actually train potential asthma educators. So next month we'll have our 4th session. We will train, we will pay for the training. The course is 2 days. The provider office has to, you know, foot the bill, if you will, for the test itself. And we will also train staff who may or may not be eligible to be a certified asthma educator or to bill, because we feel like we want to build the inventory of knowledge at a minimum in practices for HealthFirst. Our challenge then really is, you know, Doug alluded to the DISRIP program in New York State. Sort of where does all this fit, and what will value-based payment bring to us? What are going to be the funding streams? How can we include navigators? Rashi Kumar is here with me, who manages our grant portfolio at HealthFirst, and we're beginning to have a sense that we can show the efficacy of these peers or navigators, et cetera. How do we fit them into our new way of looking at care, services, and of course reimbursement? And then also for managed care, we have to step outside of our comfort zone, I think, to work on this. Readmissions, we kind of understand that, but the transitions for these members is a little bit different, and obviously we have to focus on prevention. So thank you.